Hello, everyone. My name is Gustavo Sapoznik. I'm the editor-in-chief of the World Stroke Academy for the World Stroke Organization. Today, we have the privilege of having Dr. Gillian Mead, who is the professor of stroke and elderly care medicine at the University of Edinburgh in the UK. In addition, she is the co-chair of the Guidelines Committee at the World Stroke for the World Stroke Organization. Gillian, welcome, and thank you very much for joining us for this podcast.
Thank you for that kind introduction, Gustavo.
Excellent. So we would like to, pick up your brain about your next coming publication about therapeutic or pharmacological interventions in stroke rehabilitation. So as you know, pharmacological interventions or treatment in stroke rehab has been under debate. So what's the current status?
The current status about pharmacological interventions for stroke recovery is complicated. There's been a number of drugs that have been tested in small trials, and the results are inconclusive. So, for example, there's been trials of dopamine, citicoline, amphetamines, and now this individual patient data meta-analysis of fluoxetine, which is very much bigger than previous studies have reported on. I think it depends how you define pharmacological approaches. Arguably, you could say that aerobic exercise is a type of pharmacological approach because it stimulates the production of endorphins, which can enhance mood, brain-derived nuclear growth factor, neurotropic agents, which certainly in animal models can improve brain size, and certainly in systematic reviews seem to have some benefit on overall recovery. So I think the question about pharmacological agents depends a little bit on what you define. There's also obviously research on stem cells, which I'm not an expert in, but they've given mixed results as well. But having said that, I think there's good evidence for some pharmacological approaches for specific post-stroke problems. So for example, post-stroke spasticity, we know that Botox is a good treatment. So I think it very much depends on what your question is.
So let's be more specific then. So if we go to your publication and the project that you completed about the meta-analysis, so are SSRIs helpful for stroke in stroke recovery, or more specific, we can go back to the FLAME study of fluoxetine. Can you comment on that?
Yep, sure. So there was great excitement when FLAME was published over 12 years now, and it showed that fluoxetine, when given early after stroke, seemed to promote motor recovery, and also seemed to improve the modified Rankin scale. So this caused a great deal of excitement in the stroke world, but of course it was a small trial, so it needed to be replicated. So Professor Martin Dennis and myself got together with Eric Lundstrom and Veronica Murray, who now sadly has died, Graham Hankey and Marie Hackett, and designed a protocol for 3 trials in different countries to explore this in much larger numbers of patients. So we worked together to produce a protocol and then delivered 3 trials. Focus was published in Lancet, and then Affinity from Australia, New Zealand and Vietnam was published in Lancet Neurology, and Effects was published in Lancet Neurology as well. That was the Swedish one. So we'd got all those 3 trials published, and we planned to do an individual patient data meta-analysis, and that's what now we've reported in IJS.
Excellent. So what are the main findings for the audience? So what did you find?
We found no impact of giving fluoxetine early after stroke on modified Rankin score at 6 months, and the confidence intervals were narrow, so we can be confident that overall fluoxetine does not improve stroke recovery. We did find that there was a small reduction in the risk of depression at 6 months, which was expected. There was also a reduced need for antidepressants, which fitted with the finding that there was less depression. We did, however, found that it increased falls risk, increased fracture risk, and it also increased the risk of seizures, although the absolute risk of these events was quite small.
Understood. So it seemed to be not effective and probably raise some concerns in terms of safety. Is that right?
Yeah, that's right. Yeah. So our recommendation is that it shouldn't be given routinely to promote recovery.
Have you find any, or were you able to do any subgroup analysis that may potentially benefit, or perhaps if the numbers didn't allow, do you think that is there any role in some specific subgroups? So I'm not talking about the specific study that you did, but based on your clinical expertise.
Sure. We looked at several pre-specified subgroups according to whether there's been motor deficits at baseline. There was no difference in terms of benefits in that group. We also looked at a number of other different subgroups, for example, stroke severity. We looked at people with aphasia at baseline. So there was no evidence of any effect in any of the subgroups that we looked at.
So many people from our audience may wonder, what should we do with patients who had a stroke and have depression? What is your management or usually your recommendation?
Sure. That's a very different question from giving fluoxetine to try and promote recovery after stroke. So there's been a lot of research on how to manage depression after stroke, and obviously it's a big problem. About 30% of patients will experience that. I would suggest looking at high quality Cochrane reviews for the evidence, and that does include antidepressants in the treatment. It also includes cognitive behavioral therapy, and then there's evidence emerging about non-invasive brain stimulation as well, and potentially aerobic exercise. So I think it's important to emphasize that these trials don't give us answers about the treatment of depression, but they give us answers about promotion of recovery.
Excellent. So thank you very much. That's a great answer. So in summary, what you are telling the audience is look for high quality evidence. SSRIs and cognitive behavioral therapy may be beneficial based on the evidence, but for stroke recovery, so far we don't have the evidence that SSRIs are beneficial and may be harmful. Is that a good summary?
Absolutely correct. Yes. Yeah.
Excellent. So what would be your take-home messages for people who, are facing patients with a stroke and they are, thinking about how can I help improving recovery in those patients, let's say after 1 month of a stroke or 3 months of a stroke?
I think that there's a number of different approaches to promoting recovery, and I think it all starts with the hyperacute care, and I think it's incredibly exciting that we now have treatments such as thrombectomy and thrombolysis that we know will improve the outcome, and particularly for thrombectomy, the numbers needed to treat are very small. So those hyperacute treatments are very important, but it's crucial that we looked at the whole patient journey. So looking at stroke unit care, looking at a wide range now of rehabilitation approaches that we've got. It's also important to remember secondary prevention, but I think the area that I'd like to mention specifically in terms of recovery is some of the longer term complications from stroke that are often neglected. So fatigue and apathy and physical deconditioning, for example. So if you can target those even late after stroke, you can make a difference to overall recovery many years later. So essentially a multifaceted approach, and it's been summarized by the World Stroke Organization Guideline Committee and published last year in the IGS if readers want to have a look at that as well.
Thank you, Gillian. There was a meta-analysis, last question, there was a meta-analysis in Frontiers of Neurology by Dr. Liu and colleagues in 2021, similar about the use of fluoxetine for stroke recovery. And they found a benefit in Fugel-Meyer So those were some of the findings, as well as the Bartelli index. Do you think that this is real?
I think they included in the meta-analysis of 3 large fluoxetine trials, and we didn't include the Bartel or the Fugel-Meyer, although arguably I could say that Bartel is probably similar to the modified Rankin score. They included some small trials which I think potentially suffered from bias. So I'm skeptical about the results. The other thing to say is that we looked at motor recovery, and we used the stroke impact scale, which actually has a motor scale, and we found absolutely no difference in self-reported motor activity. So I would argue that what the patient says is more important than actually a measure like the Fugel-Meyer, but I'm sure other people would disagree with me on that.
Thank you very much, Gillian, very much appreciated. And I hope that our audience enjoy this very informative and exciting discussion. Thank you very much for listening.
Thank you.